The TMJ-TMD conundrum is real and has been puzzling the dental and medical professions for decades. This is the TMJ-TMD Demystified podcast with Dr. Tony Urbanek, where we'll connect the dots between TMD symptoms and the actual cause. We'll tackle common TMD misconceptions and educate you, the practitioner, about a simple, tested, and proven TMD solution that has already provided relief to thousands of patients, while helping practitioners build an additional source of income free from insurance control. Welcome to this episode of the TMJ-TMD Demystified podcast.
Welcome, TMD Warriors. We're here for the next episode of TMD Demystified. It is Tuesday morning, and I, as usual, am going to make the next episode of this podcast. My name is Tony Urbanek. Today's episode title is, quote, "Is it a toothache or TMD?" Toothaches are frequently confused with the cause being temporomandibular joint disorder. That fact has been known for quite some time. Just by process of elimination, sometimes when the patient comes in and says, "I have a toothache, I swear the tooth hurts," and the dentist does his usual workup, which is an x-ray, series of x-rays, maybe, an examination, and announces to the patient, "There's nothing wrong with your tooth." Patient points to the teeth or tooth or the area where the toothache is and says, "No, doctor, I have a toothache." And the dentist says, "No, ma'am, no, sir, there's nothing wrong with this tooth." This is a very common, relatively common event. And if you are a dentist, you have experienced this. Have a patient come in and say, I have pain here in one or more of these teeth, and you can't find anything wrong with them. As I've stated before, these podcasts and these episodes are becoming more and more popular with the public beyond the dental profession. So I'm gearing it actually in this particular case and going forward to future podcasts to both groups, patients and doctors. The presentation is the same because the confusion about this is constant. Now, when a patient presents to a dentist and claims, "I have a toothache," and the dentist can't find anything wrong with the tooth, one or more of the following things will and can occur, in my experience. Number one, the patient gets frustrated, leaves in a huff, and thinks the dentist needs to go back to school. Second thing that might occur is that the patient talks the dentist into removing a perfectly healthy tooth or teeth in an area of the jaws. It can happen in both upper and lower jaws. I might comment on that in a minute. Number three, the doctor says, I'm not going to remove perfectly healthy teeth. I will not do that," but doesn't give the patient any option other than, "There's nothing wrong with your teeth. I have no idea why you feel you have a toothache," which is the preferred outcome. Dentists should be ethical, and if they feel that there's nothing wrong with the tooth, they should not be encouraged or talked into it by the patient. Or number four, the dentist is familiar with my work and the actual explanation of why that occurs, why there is a confusion like that, has been to one of our seminars or read some of our material on exactly how a toothache, a TMD problem can feel like a toothache, a TMD problem can feel like a toothache, and sends the patient to our practice or one of the other practices throughout the United States who uses our device and protocol to treat TMD non-surgically, correcting the cause rather than the symptoms. It creates the symptoms too. I mean, it corrects the symptoms, but you're correcting the cause. You're removing the cause, and the symptoms don't occur, and the symptoms die down. And this is a fairly common occurrence, and the patients will present with, most commonly, and this is what I've seen for years, pointing to usually lower teeth, lower first and second molar area, but it can be upper teeth also, but always posterior teeth, almost exclusively first and second molars. This same kind of phenomenon occurs with oral surgeons. I think if you're an oral surgeon, if you are an oral surgeon, you have experienced this. A patient comes in and says, I have pain here, and you get your x-ray, you get your Panorex, and you see that there are 4 impacted teeth, upper and lower, in all quadrants. And you tell the patient, well, I don't see any infection. I don't see any tumors, masses. I don't really see anything that would describe pain with these wisdom teeth, but it must be your wisdom teeth, so we're going to go ahead and take them out. And you can have non-symptomatic wisdom teeth. If you're an oral surgeon, you have taken out a bunch of non-symptomatic wisdom teeth for the right reason, because you take wisdom teeth out so they don't create problems in the future. The problems created by wisdom teeth, third molars, are frequent decay on the adjacent teeth. Cysts and tumors can frequently occur. So that is why impacted wisdom teeth should be removed, even if they are non-symptomatic. But the oral surgeon will remove wisdom teeth when the patient says, I have a toothache, and they see no symptoms, they're not infected, and they'll get the wisdom teeth out, and the patient will be back for the post-op check maybe, and they're still a little sore, and then they'll be back in a month or two and say, I'm still having pain again. And the oral surgeon says, well, I took out your wisdom teeth. I don't see any reason why you should be having pain. And the answer is they need to be thinking about pain coming from the temporomandibular joint disorder. And it is not referred pain. The doctors can't even explain why the mechanism of, quote, referred pain. They use that euphemism, they use that term loosely because it sounds good, but they have no idea how that might work. Referred pain. In other words, you have pain in one area of the face or jaw, and it's coming from some other area, and they might say, it's coming from your sinuses or coming from your temporomandibular joint, but they can't explain how the pain gets from here to here. And that was my discovery. How does that happen? How do you get pain, which is actually originating in the temporomandibular joint, which ends up feeling like a toothache? I've spoken on it so many times, but the mechanism is very well known. The mechanism is very simple if you know a little bit of cell biology and a little bit of anatomy. Fortunately, I did have the credentials, having degrees in dentistry, medical degree, a degree in academic cell biology and gross anatomy, and a couple years doing research as a fellow with the National Institute of Health, National Institute of Dental Craniofacial Service. So here's what really happens. Here is the explanation, and I've spoken on it all, but it applies. I've spoken on it before, but it applies directly to this phenomenon when patients come in and says, I have a toothache, and you can't find anything wrong. So chronic inflammation, that is the result of damage to the temporomandibular joint. If you damage a joint, in this case, we're speaking about the temporomandibular joint, damage to the joint which occurs to this joint for only 3 reasons. chronic bruxism, clenching and grinding over years, acute trauma of various kinds, motor vehicle accidents, 4x4s off the back of a pickup truck, bar fights, athletic accidents. Here in Tennessee, horse accidents, being thrown by a horse or kicked by a horse, acute trauma. And then the third is functional malocclusions of the jaws, difference between centric occlusion, centric relation, which is severe enough to damage the temporomandibular joint. Those are the only three reasons why you get damage to the joint, which then, if it doesn't heal, will turn into chronic inflammation, because we know that inflammation is the body's response to damage, any kind of damage in any part of the body. Inflammation is the body's response to damage. But if it is not successful in healing one way or the other, no matter what tissues it's in, it then turns to continuous chronic inflammation. And chronic inflammation has different cell types and different cellular mechanisms and different cellular exudates that create its own set of trouble, own set of problems. But when this joint becomes chronically inflamed, it sends an autonomic nervous system signal to the muscles that move this joint. In the case of a elbow, it would be a signal from the elbow to the brain stem that says, I'm inflamed. If it's the temporomandibular joint, the signal goes from the temporomandibular joint to the brain stem, and says, I'm inflamed. The brain, in turn, takes that signal, modulates it, accepts it, and says, I am going to help you out, and sends a signal back down through the autonomic nervous system, sympathetic portion, in this case, to the muscles that move the jaw, to hold the jaw still, to enhance healing by holding the jaw still. And the muscles begin to tighten, to constrict. And when they constrict enough continuously, they pull on the periosteum where those muscles are attached. In this case, the signal comes down to the muscles that attach to the mandible, the lower jaw, in the area of the first and second molars, and the muscles get tight and pull on the periosteum where the nociceptors are. You know, you have to say nociceptors rather than pain receptors, because doctors have to sound important by speaking in Latin terms. Noci is Latin for pain. Pain receptors in the periosteum next to those teeth. And when those nociceptors get stimulated by the bone pulling on the periosteum, to the patient, it feels like a toothache. That's the mechanism. It's very simple.